All right. Well, I'm sure more people are going to start coming as soon as you start talking.
Sure.
Um, you want to just get going?
Yeah. Yeah.
Perfect.
I
All
mean,
right.
205 is going to be going for another few hours, so I've got time.
You got time?
Yeah.
I'm glad you found a way to kill it at least this
Yeah.
way.
Yeah.
Well, I'll just introduce you real quick. Thank you all for coming to another one of these multidisciplinary trauma conferences. And today we're very fortunate to have Kate Buesser, one of our orthopedic fellows, here to talk about what I think is a really interesting topic. And it's, really what this conference is about, because we're going to be talking about, I don't want to steal the thunder, but resuscitation and orthopedic trauma and markers of it. And, this is a great example of us trying to understand another service or another medical field and their way of practice when it differs from others. And so I think this is a great time to try and get on the same page. And it's actually stemmed from a couple of cases recently and some safety reports about care and all this. And I said, this is a perfect topic to talk about then. So with that, I don't want to give away too much, but Kate, the floor is yours.
All right. Thank you. Yeah, a big appreciation to Dr. Knittel for the opportunity to present. And it's been a really actually wonderful time kind of diving into critical care literature, emergency department literature, and trying to educate myself on things that I don't know about, things I thought I knew about. So without further ado, so just an outline for tonight. So a brief history of orthopedic trauma care. So we're going to start roughly in the 1950s and then bring it through to present day. And there's three main eras within that we'll go over. And then we're going to be talking about the orthopedic focus on physiological markers of resuscitation. And for better or for worse, we tend to be hyper focused on lactate. We'll have a conversation of some of the etiologies of hyperlactinemia, and hopefully have a conversation about other markers that maybe we should be paying more attention to as traumatologists. So as Dr. Knittel had mentioned, we had some recent patients that stimulated some of these conversations, and this is one of them that I was involved in. So this is a 30-year-old male. He presented after an unhelmeted ATV crash. He was a rollover at about 2 p.m. No reported loss of consciousness. And just up here, AP and lateral of the distal femur and the distal tibia. And this gentleman has what I would describe as a floating knee injury, meaning the knee joint itself is not connected to any part of a stable skeleton. An injury that was first described in 1975 and then further classified in 1979. And this is a type 1 floating knee, meaning this is a diaphyseal injury to both bones. Now, some of the things that we think about, I think it's really easy as orthopedic surgeons to really jump right to the x-rays and say, well, how do you want to treat this? What do you want to do about it? Start thinking about fixation, start thinking about reduction strategies. But Dr. Boyer, who's one of our hand surgeons here, really produced a great way to think about these patients from his experience taking care of trauma patients up in Toronto. And it really starts with the patient moves to the extremity, and then really the last thing that we should be thinking about is fracture. And so for this patient, start thinking about what are associated injuries to these body systems. These floating knee injuries are almost always associated with high mechanisms, most commonly motor vehicle crashes. And we know there can be up to 38% of patients with intracranial injuries and associated pelvic ring or acetabulum fractures. Luckily for this patient, he had just abrasions to his left eyebrow, a safe airway, no problems with breathing, no abdominal tenderness, and no step-offs in his entirety of the spine. And his GCS was listed at 15. Next, moving to hemodynamic status and resuscitation. And again, we'll kind of dive into this a little bit later in the lecture here. But this patient was tachycardic to the mid-20s, but otherwise he really was in compensated shock, being able to maintain his systolic blood pressure in the 130s with a MAP of 83. His initial lactate was at 4.4 and his venous pH was 7.3. His base excess was listed as 0. So, thinking about this, the high lactate, kind of a quick jump from an orthopedic perspective, I immediately think of hemorrhage as the main cause for this. And again, like I talked about, we'll probably have hopefully a more nuanced evaluation of lactate later on the lecture. Now, moving on to the extremity. What is the vascular and neurologic status of the extremity? So for this patient specifically, in a floating knee, you get really worried about the popliteal artery as it goes through the soleal arch just distal to the knee joint. Now, with this type 1 floating injury, the tibia fracture is a little bit further distal. So not as much concern about that, but as the tibia fracture becomes more proximal, you start worrying about that tethering and potential stretch injury to the artery itself. It was reported that he had non-palpable but Dopplerable distal pulses. And I think one piece of information that we're probably missing in this patient that I would recommend to all of my residents who are evaluating fractures about the knee, whether that's an isolated distal femur, isolated tibia, is that to have the ABIs be performed, as that even though you can have palpable pulses, you may be missing some intimal injuries that can be picked up with a CTA. So didn't have that piece of information, but turned out to be not important in the long run. Now, specific to fractures, so we're really on a scavenger hunt for open wounds. The X-ray that I presented in the last slide, there was some concern about an open injury, especially at the tibia. You can see some air within the medial soft tissues, and just the valgus displacement of the fracture itself just lends itself to some concern about a tearing or a tension failure of the skin. And then also associated with this extremity is whether or not there's other orthopedic injuries. So some of those injuries are things that you can look for before you're going to the operating room, such as a femoral neck injury. You can pick that up on CT, hopefully not on X-ray, because that's probably already displaced. But then thinking about ligamentous injuries to the knee, and that may be something you add to your checklist in the OR of after stabilization, after the patient has been cleaned and their dressings are on, that you need to check their knee afterwards. And last but not least, thinking about the fracture itself. So there's a pathway here that we can go and temporize these fractures, or we can go through with definitive fixation. And for temporization, that can include a whole host of options, from splints, traction, to surgical external fixation. And then definitive fixation, there's also a whole host of options when it comes to fixing bones. But for these two injuries, the standard of care is really reamed intramedullary nails. So this decision whether to temporize or definitively fix these injuries is really the focus of the history of orthopedics. So we're going to go through a little bit of a timeline and look at some of the literature that helps dictate whether or not we should be moving towards early fixation versus delaying them and allowing for appropriate resuscitation. So before the 1950s, it was considered that patients were actually too sick to operate on. So there was significant concern for fat embolus syndrome. So there's a lot of hesitation about bringing patients to the operating room for fracture fixation. Now, in the 1950s, the development of the AO occurred in Europe, and this is the Association of the Study of Internal Fixation. And they set out to define principles of fracture management, implant design, manufacturing, education, and research. So now you start to have a group of orthopedists who are focused on trauma, and really being able to share literature, share patient experience, and start to develop pathways for how we should be managing our patients. Now, in the 1970s, some of the pioneering work that led to this first era, which is the era of early total care. This was done in Finland. So this was a 1977 paper. They looked at 47 patients who had multiple injuries, were treated in an ICU, and had at least 2 long bone fractures treated by early fixation. The definition of early fixation at this time point was within 2 weeks. And I think for our current orthopedic surgeons, we would consider 2 weeks quite delayed. But at the time, this was getting to the operating room quick. So these patients, other injuries that they had, 22 had cerebral injuries, 6 with abdominal injuries, 16 with pelvic fractures, 5 with spine fractures, and 2 with vascular injuries. And I want to draw your attention to table 2 here. So along this study period from 1967 to 1974, they started treating patients less and less conservatively. So you have 67% of patients being treated conservatively in the late 60s, and this is down to 35% in the early 70s. But the most important thing here is that they found that they had lower rates of patients with fat embolus syndrome as they treated patients less and less conservatively. So they concluded that primary internal fixation was preferable to the more conventional conservative methods of treatment. Another kind of fun thing that they boasted about is that 32 of the 47 patients that they studied were able to leave the hospital within 3 months. So again, I think, times have changed a little bit, but at the time, this was, impressive recovery, and mobilization was a big part of that. So this led to the era of early total care, and this was primarily in the 1980s. And so this paradigm shifted from patients were too sick to operate on to too sick not to operate on. And there were 2 groups, one out of Buffalo and one out of Dallas, who really supported this type of approach to orthopedic surgery. The first was Dr. Border, and this was the team in Buffalo. This was a paper in 1986, and they looked at 56 patients with blunt trauma and an ISS of 22 or greater. And they were studied for the effects of immediate versus delayed fixation of femur and acetabular injuries on what they defined as the pulmonary failure state. And that was an alveolar oxygen tension, difference of 80 to 100, fever, and leukocytosis. Now, the groups on the left-hand side of table 4, group 1 underwent immediate operative fixation, post-operative ventilator support, and were sitting up at 30 hours. Group 2 had 10 days of traction and post-operative ventilator support. Group 3 had 30 days of femur traction and immediate extubation after surgery. And group 4 was the most severely injured, and they defined this as special circumstances that increase the duration of the pulmonary failure septic state. And one thing I want to draw your attention to here is the acute care days. So from group 1, and again, group 1 was immediate operative fixation, compared to group 2, which was 10 days of traction, doubled the pulmonary septic state compared to group 1. And the 30 days of traction increased the pulmonary failure factor by 3 to 5. So they concluded that femur traction really is the first in a series of steps that has significant probability of leading to the grave, via bacteremia and multiple system organ failure. And they really suggested that the orthopedic traumatologist should be members of the frontline trauma team and have early access to these patients. And then going into the team out of Dallas, this is a 1989 paper by Dr. Bone and his team. And it was a prospective randomized study comparing early and delayed reduction and stabilization of fractures in patients. And when they were able to stabilize the fracture early, the incidence of pulmonary complications was higher, the hospital stay was longer, and the number of days in the intensive care unit was increased. So they felt that getting to these patients early was extremely beneficial. So if you're orthopedic traumatologist in the 1980s and you limit your orthopedic reading to these 2 papers, you may feel that you just have a hall pass to go and take care of all these patients all the time early in their care, and you don't really have to think about any detrimental effects because there's so much benefit to your early involvement. But there was another group this was a study by the AO Foundation in 1985 by Dr. Eck. who felt that there needed to be a little bit of pumping of the brakes as they looked at over 1,000 patients and found an unexpectedly high rate of pulmonary complications, most notably among young patients between 20 and 30 years old, with no pre-existing disease and without evidence of thoracic trauma. More and more studies in that area reported high rates of ARDS and multi-organ dysfunction in the setting of severe chest injuries in patients in severe hemorrhagic shock. So this led to a kind of an interval era, which is termed the borderline era. Now, this is a time, previously we had been unable to quantify the biological impact of the first hit and the additional effect of the second hit in the two-hit trauma theory. But advances in molecular medicine helped understand inflammatory mediators that were involved in the response to multi-system trauma that was leading to SIRS, ARDS, and multi-organ dysfunction syndrome. Leading into this two-hit theory, I'm sure most of us are familiar with this, but the first hit is the activation of the innate immune system. That includes macrophages, leukocytes, and natural killer cells. And the inflammatory cell migration is enhanced by the production of acute phase reactants, and mediators. These mediators can be measured. There's a few papers from this era that are looking at IL-6 and TNF-alpha as partially as markers of resuscitation and whether or not patients were ready to return to the OR. But especially at our institution, these inflammatory markers are really limited by their availability as an easy and reliable lab value. And I actually called our lab here on the South Campus, and IL-6 is a send-out test. It takes 4 to 6 days to result. And TNF-alpha is also a send-out test. Both of these are to the Mayo Clinic, and it takes about 2 to 8 days for these to result because it is only run on Thursdays. So a lot of these immunologic markers are unavailable at our lab here, and it makes it a really difficult thing to rely on in terms of being able to understand when patients are ready to go back to the OR by simply these markers. Now, the second hit here is the stimulus, and it's usually less intense and normally resolves, but there are patients who are vulnerable to the secondary inflammatory insult, and it can reactivate and precipitate MODS. The second hit can include sepsis, surgery, and other ICU-related adverse insults. A lot of the work within the orthopedic trauma literature was performed by Dr. Papp and his group out of Germany, Great Britain, and Switzerland. And they were able to categorize patients into extremis, unstable, borderline, and stable patients based on clinical parameters of shock and acidosis, coagulation profile, temperature, and soft tissue injuries. And so if we know that some of these patients are at higher risk, and we recognize that surgery is of any type really is a controlled trauma, what can the orthopedic traumatologist do to minimize this hit while providing a physiologic benefit to the patient early in their trauma course? So this led to the era of damage control orthopedics. And this concept originated from the United States Navy, in which is defined as the capacity of a ship to absorb damage and maintain mission integrity. The first time that this was a concept within the medical literature was in the Journal of Trauma, Injury, Infection, and Critical Care in 1993, and was an approach for improved survival and penetrating abdominal injuries by our general surgery colleagues. And really, this was just extrapolated to orthopedics in the late 1990s. Now, damage care or damage control orthopedics has 3 stages. So first is early temporary stabilization of fractures and control of hemorrhage. This is for patients with a systolic blood pressure under 90, temperature below 32, and platelets below 70. There are some other clinical parameters that do favor a DCO strategy, including a pH of less than 2.4, a serum lactate of greater than 2.5, anticipated surgical time of 90 minutes if that's for definitive fixation, in patients who have undergone transfusion of greater than 10 packed red units. The second stage is a resuscitation stage for rewarming, correction of coagulopathy, and maintenance of hemodynamics. And this is the first time in our literature that you start to see lactate used as a pretty significant and marker of resuscitation and really a goal of resuscitation. And I think we'll talk a little bit about, lactate as a prognostic marker versus lactate as a goal of resuscitation and whether or not that's beneficial. They also looked at base deficit and urine output as endpoints for whether or not these patients were ready to return to the operating room for definitive management. So as the care of trauma patients improved, both in our ICUs and in the emergency departments, with fluid resuscitation strategies evolving and monitoring becoming much more efficient, a new approach to orthopedic management became much more prevalent. And this is known as early appropriate care. And this was introduced in the mid-2010s and can be thought of as offering the benefits of early total care and the safety of damage control orthopedics. Now, most of this work was performed by Dr. Valier and her team out of Cleveland Clinic in Ohio. This paper at the top of the screen here was a July 2013 paper that was a retrospective review of over 1,000 patients with an ISS of 18 due to multiple system trauma after high energy injury. They found that patients who had definitive management of mechanically unstable fractures had shorter ICU and hospital stays and lower overall rates of complications and ARDS compared to those who were treated later, even when adjusted for age, associated injury types, and severity. And they felt that parameters needed to be established, which would make it safe and efficacious to proceed with fixation. And this came out the recommended parameters be found, and then they published a paper in October of 2013 that defined those parameters. So they retrospectively looked at 1,443 patients and developed a statistical model to predict what level of resuscitation and improvement of acidosis led to an acceptable level of complications at a frequency of 20%. They found that patients who developed ARDS, pneumonia, and other pulmonary complications had significant lower pH values at presentation and at all time intervals within 72 hours of injury. Base excess and lactate values were also significantly worse at all time points studied. They found that hematocrit, platelet level, INR, heart rate, pressure, and transfusion requirements did not have an association with the development of these pulmonary complications. In their logistic predictive model, when acidosis had not improved to normal within 24 hours, patients were more likely to develop pneumonia or any other pulmonary complication, especially in the setting of a chest injury. Lactate was the most specific predictor for pneumonia versus pH or base excess in their model. Therefore, they ended up with a definition of EAC as definitive fixation within 36 hours of injury, as long as the patient has demonstrated response to resuscitation as based on improvement of acidosis with a lactate less than 4, pH greater than 7.25, or base excess less than 5.5. During persistent acidosis, a DCO strategy is used and the patient is continually reassessed to determine the timing of definitive care. So this brings us back to present day, and we can return to the paper that I presented at the beginning of this lecture. So if you recall, his lactate was initially at 4.4, so just slightly higher than what is recommended through the EAC strategy. His venous pH was 7.3 and base excess was 0. So all of those were neutral. So really 2 out of 3 measurements based on the EAC data were met for this patient. This patient was in class 2 shock, meaning about 15 to 30% of blood volume with loss, given his heart rate was in the 120s. Although, again, he was able to maintain a systolic blood pressure and MAPS at appropriate level. So, armed with the information that I presented clinically and the history that I presented regarding the orthopedic trauma care and the evolution that we've taken over time, I felt it was appropriate to take this patient to the operating room. And going into this surgery, I felt the plan could range from a strict DCO strategy, which was IND, enclosure of the traumatic wound over his medial tibia with external fixation of both long bones, but was aware that if the patient was adequately resuscitated and responding to such resuscitation, I could proceed with an early total care strategy, perform an IND, and intramedullary nailing of both of those fractures. So at the beginning of the case, I don't believe this patient had an arterial line for blood gas evaluation. So I just requested serial lactates. And again, based on my training, informed by the history I presented today, I thought this would be kind of an easy lab value that was quick, reliable, and could be a marker of resuscitation throughout this surgery. So I worked on this patient for roughly 4 hours. I'm not the fastest surgeon I know right now. That remains in the hands of Dr. Buesser. And, you know, I felt pretty good about reduction, getting these bones out to length, alignment, rotation appropriately, which is all the goals, going through the steps, making sure the residents were involved in this case. But then, you know, we have high fives all around in the OR, but then looking at his labs later on that night, you know, I found out about this the following morning. I was not awake at 1 o'clock in the morning, but by my standards, reviewing this case, I felt that I had caused harm to this patient based on my operative strategy. And as Dr. Knittel alluded to, I raised my concerns about this case to both our ED and anesthesia colleagues through our department liaison for patient safety events. And some of the perceived errors that I felt needed to be discussed in this case. One was the resuscitation of this patient in the trauma bay. So this patient presented at around 2 p.m. And by the time I was ready to bring him to the operating room at about 7 p.m., he had not received any crystalloid or blood resuscitation. And this was, again, with a presenting lactate of 4.4 and a class 2 shock with his elevated heart rate. Another error was my own. So in reviewing laboratory data, I just mentioned that I took this patient to the operating room at 7:51 at night, and you can see that the lab at 5:38 is there to see and was there for me to evaluate. And so I should have probably known about that and really started to proceed with more of a damage control strategy as he was not doing better from presentation to the OR. And although, you know, kind of one of my last errors, although my plan was for serial lactates during the OR, you know, I fully can admit that I was hyper-focused on the surgery itself and really didn't check in or push my CRNA colleagues to be collecting this data for me. And this is the all too common communication error that can really plague us with our patient care in the operating room. And so the responses from both the emergency department and the anesthesia department really kind of harped on our the orthopedic hyper focus of our team on lactate. And so that's why I wanted to kind of bring this up as a subject and really get to talking about this molecule and its relationship to our trauma patients and really trying to understand it from a more holistic standpoint rather than just kind of the single train of thought that I had through my training. So lactate, as we all know, is the endpoint of anaerobic metabolism via pyruvate via lactate dehydrogenase. There's a plethora of literature discussing initial lactate and 24-hour lactate clearance as a predictor of increased morbidity, including infectious and other complication rates and mortality in the trauma population. And this literature really anchors our early decision-making with respect to resuscitation and management of these trauma patients. But like I alluded to earlier, there's really a balance of lactate as a prognostic factor and a lactate as a strict measure of resuscitation. Lactate clearance is associated with clinical outcomes, but targeted attempts to correct an elevated lactate to a specified value or determine optimal threshold for lactate correction have really not resulted with improved mortality. So really, when interpreting lactate levels in the trauma population, we really have to have a more nuanced understanding of these factors that contribute to hyperlactinemia. And I wanted to review a few of those factors. I'm sure there are more. I'm not even touching on, you know, medical comorbidities and how those can have an interplay with these lab values. But at least we can hit on 4 of the main ones that I found. So This first one, and this is really, this is the single train mind that I had. When I see an elevated lactate as an orthopedic surgeon, I immediately think of hemorrhage. As really, if we're involved with these patients, we know that femoral shaft fractures, you can lose up to 1 to 2 liters of blood volume into a thigh, and that's even in a closed scenario. And then obviously with pelvic ring injuries, you can lose a significant amount of blood volume into the pelvis. And so, anytime I see a lactate, I thought, boom, this person is under resuscitated and needs crystalloid resuscitation. And I know that's much to the chagrin of our emergency department colleagues because they obviously have a much different literature base in that crystalloid resuscitation and large volumes of crystalloid resuscitation really was a pre-2000s resuscitation model. And there are more modern methods. So in reviewing some of the emergency department and critical care literature, they raise concerns about increased mortality with high volume crystalloid resuscitation. Some papers citing a 9% increase in ARDS per 500 milliliters of volume given. There's also a risk of resuscitation injury, where the volume of resuscitation removes the initial clot formation and increases hemorrhage volume in addition to causing dilutional coagulopathy. There was a shift in the early 2000s from high volume to what they term hypotensive or limited resuscitation that had 2 basic tenets. This was either delayed resuscitation and withholding of fluids until definitive bleeding control and definitive bleeding was controlled, and then a permissive hypotension where small aliquots of fluid were used to maintain a systolic blood pressure between 80 or 90 or a MAP of 65. There's also been a much higher emphasis on blood and blood products as guided by TEG profiles, and also consideration of TXA in the emergency department based on CRASH 2 data. Regardless, a lot of these papers were still recommending serial lactate and base deficit measures to ensure that resuscitation strategies were being followed and that these patients were improving. One thing that I still have some questions regarding the decision not to this patient any crystalloid resuscitation while in the emergency department. And I do think that it can be sometimes be dangerous perhaps to assume euvolemia at the time of injury. I can just think of myself, at the end of a long surgery day, I certainly have not hydrated enough and can probably use just some baseline resuscitation. So while, I do recognize where they're coming from in terms of the literature that they follow and the harm that can be caused by crystalloid resuscitation, I still think there may have been some wiggle room, especially in a young, healthy patient without any comorbidities. Now, some of the other, I wanted to go over 3 other etiologies of hyperlactinemia. And the second one here is increased oxygen utilization versus inadequate oxygen delivery. And this topic really has a lot of controversy. And this is a lot of literature actually from septic shock patients in the 1980s. And these patients were provided with hyperphysiologic oxygen levels and showed no improvement in overall outcome. Another paper in the mid-90s randomized critically ill patients to supernormal oxygen delivery or usual care, and the oxygen consumption remained unchanged in each group, with a substantial increased mortality in the supernormal oxygen group. So increased oxygen delivery neither increased oxygen consumption nor decreased lactate levels, indicating that hyperlactinemia is more frequently caused by impaired tissue oxygenation rather than by impaired oxygen transport. Another meta-analysis of over 1,000 patients by Dr. Halen in 1996 concluded that interventions designed to achieve supraphysiological levels of cardiac index, oxygen delivery, and consumption did not significantly reduce mortality rates in the critically ill patients. And last but not least, just in looking at this topic within the trauma population, there was a 2018 systemic review of over 60 articles evaluating the use of supplementary oxygen for spontaneously breathing patients and found evidence really lacking for its use. So this oxygen availability is probably not the highest contributor to the increased lactate in our patient population. Now, the one that really was one of the most interesting that I read about in preparing for this is this bioenergetic failure. And I think this is a really interesting one and really changed my perspective of how you evaluate lactate in some of these patients. And by this subject, the hyperlactemia is actually caused by the stress state itself. So the beta-2 adrenergic stimulation mediates glycogenolysis with increased production of glucose and pyruvate that exceeds the metabolic conversion in the Krebs cycle. Again, this is via pyruvate dehydrogenase and one of the critical coenzymes, thiamine pyrophosphate. And therefore, pyruvate is really just shunted towards the lactate pathway. And additionally, there's probably some issues with energy metabolism in the inflammatory state, which is the underlying thought behind some of the HAT protocols. And that's found in septic shock literature, where they provide hydrocortisone, vitamin C, and thiamine to help decrease the overall inflammatory status. And going back to thiamine pyrophosphate, that's a critical coenzyme. So that's really the only therapy that's been shown when given to patients to decrease lactate levels, just specifically via this Krebs cycle pathway. Now, last but not least, trauma is not always random, and I would say fault is usually not random. And so drugs and alcohol are known to be a big problem within the trauma population. I mean, really, this was not an etiology that I really considered prior to researching for this presentation. I see positive drug screens all the time, but I really don't think about or didn't think about how that may cause a derangement in some of the parameters that I'm using to consider for resuscitation. So, again, reviewing the patient safety event, the emergency department colleagues defended their decision against resuscitation, again, based on his positive drug screen, which was positive for amphetamines and cocaine, in addition to the previously stated concern regarding dilutional coagulopathy and actual increased hemorrhage with large volume resuscitation. Now, I thought this was really interesting, though. There's literature out of Shock in 2005 that investigated the effects of cocaine and alcohol on the predictive accuracy of lactate and base deficit in trauma patients. And they looked at over 15,000 patients retrospectively. Patients with positive drugs and alcohol screens had significantly higher initial lactate, base deficit, and ISS, but no increase in mortality, ICU, or hospital length of stay compared to patients that did not screen positive for these substances. Multiple logistic and linear regression models confirm that lactate and base deficit as independent predictors of mortality they were independent predictors of mortality, ICU, and hospital length of stay when for alcohol and drug use as covariates. So they concluded that alcohol and drug use, although common in trauma, do not impair the predictive accuracy of admission, lactate, and base deficit in trauma outcomes. So although, these substances can cause laboratory derangements, you should still consider an elevated lactate as an important marker of really the stress state of the patient. If you're going to check lactate, then respond to it. So, ultimately, I think the difficulty in the patient that I presented and all the patients we treat is the contribution is trying to figure out the contribution of each of these etiologies to the presence of high lactate. And like I said, and how their additional medical comorbidities really influence this lab value. But really, what this patient experience reinforced to me is, to Dr. Knittel's point is how important it is to converse with our colleagues and other departments and really avoid being siloed within our own literature of our own specialty. The fast-moving nature of our jobs does not always allow us to reach out to colleagues in the moment and understand the, vast evidence base for their clinical decisions. But I do want to thank Dr. Knittel for the space and time to give a orthopedics perspective to some of the decisions we make, and I look forward to some of the conversation that has stemmed over from this lecture.
Okay, thank you very much for that. It's a great talk. And I like the honesty and the real like live case approach to it. So it really puts it all into perspective really nicely. And I mean, I wrote a ton of notes. I don't know if I can even read my handwriting because I was trying to furiously write stuff. You know, there's so many points about trauma care that come up in this. And the last point I wrote was, I think I wrote, were crystalloids the best fluid for resuscitation? And I think something just like that, that's, something that I think we took for granted in trauma care for a long time. And now we're actually looking at that and saying, well, there are better strategies than just fluid. And, the fact that this is a lot more complex, we aren't just transfusing fluids to make a number better. Like there's a lot more of an understanding of the pathology going on. And we're realizing how much more complicated this actually is and how much better I think our resuscitation can be. So I think this feels like just like the tip of the iceberg in terms of understanding and kind of where we're going to go with this knowledge, of what is a lactate, what should we actually follow, and it's not that it's wrong to follow it, it's just what does it actually mean. And I've thought a lot about this case and these cases as they come up, both in the ICU side of things, and for the OR, and looking at from, I would say, the orthopedic perspective of, what you're looking at is, can I go ahead with the surgery? What is the best approach surgically to fix this patient based on, what I see in the labs in terms of the resuscitation? And the question is lactate, like you said, does lactate equal better resuscitation, or does the lactate equal a lower stress response because of a better resuscitation? Does our fluid that we give, does the volume that we give actually lower the lactate? Does it just dilute the lactate? Or is it actually fixing the underlying problem that's causing the lactate to go up? And I mean, this is what I love about trauma is this whole side of physiology that it feels like we don't spend enough time on. So I think thank you very much for your insight onto this, because I think it helps us all to understand, when the orthopedic resident comes to us and says, can we run a lactate? Now we know why. And now we can have a different conversation and say, I know what you're looking for. I'll just ask one question. You brought up, especially in the case you mentioned, the path of the popliteal artery. If the popliteal artery was out, wouldn't the lactate be up? I guess, where would the lactate utility come from in terms of resuscitation when you have like an actual ischemic problem then versus a stress response?
Yeah, I mean, I guess in that scenario, I feel like the question is not whether or not to be taking the patient to the we're going to the operating room at that time. So again, I guess I wouldn't even really consider, this sounds bad. I wouldn't even look at the labs, because it doesn't matter what they read, because we're going to have to manage them intraoperatively. So, I feel like I use the strategy of looking at labs, looking at, the flow sheets. This is all, while I'm at home looking at patients and not actually laying eyes on them. And I think that's, another part of this. We're not around these patients all the time. I know we've had a discussion, lactate may be important, but base excess may also be important, and really just looking at the patient may be the most important part of it. So, I think we find these markers important at times, and then we ignore them in others. And it can be really just based on the clinical scenario. And I think that, just raises the complexity of trauma, because some things matter at some time points, and at other time points don't.
I know we have a bunch of surgical colleagues, both from the ICU. I know we have some anesthesiologists. I'm curious if anyone else has thoughts about lactate, specifically for orthopedics, but maybe just in general.
And I guess I'll ask a question. I mean, it seems like lactate comes up in most of our literature, and I'm just curious, like in the general surgery literature, when looking at clearance, is lactate something that you guys use, or is it more a combination of other markers of resuscitation?
I'll let other people speak up first if they want, before I do.
This is Lindsay. I think that in a healthy trauma patients, lactate is a great marker for a lot of things. But I think those of us who worked in the ICU with less healthy patients have all seen the examples of patients that you could give all the crystalloid in the world and they're never going to clear their lactate. And, maybe you embolized half their liver, maybe they were already a cirrhotic, maybe they have right heart failure and a congestive hepatopathy, but there's definitely examples of patients that you have to realize that maybe your point of care ultrasound or other things are going to be more helpful in guiding your resuscitation.
Hey, this is Grace as always. Oh, go ahead, Lindsay.
Well, what I was going to say is ultimately this is the single question that I feel like you spend most of the time answering in a critical care fellowship, right? Is volume too much, too little? Like, what's enough?
Yeah, for sure. Grace, did you want to add something?
Yeah, I'm sorry. Me and my husband have been calling back and forth because he left his key inside and locked it. So I missed the first part. So I don't even know if this is even pertinent. I apologize if it's not. But I would just say, also keep your trauma surgery colleagues in the loop. You're like, lactate's going up intraoperatively and you're not sure why, and you don't think you have a lot of orthopedic blood loss, or maybe something going on in the belly or the chest or elsewhere. And please feel free to call us sooner rather than later so we can come and put an ultrasound on the belly or whatever, provide a second opinion about what may be going on.
Yes, for sure. Yeah, I think that's a, in terms of looking at it, and I think we talked about this, Kate, in my mind, I see lactate used all the time. I think I see it wrongly interpreted a lot of the time. And it's, the question of, okay, your lactate's up. That's great. What is that actually telling you? And, looking at the association between lactate and volume status, I say it's pretty poor. What it means is I know something bad is still going on, maybe, and I need to do something about it. And saying, okay, if I feel like I've adequately resuscitated, that's where, to Grace's point, it's okay, what else could be going wrong? And if I can't find anything, okay, why is the lactate still up? What happened to the liver? What about these other reasons that you mentioned? Are we not getting rid of that lactate? And I fully expect, to me, this is such a big part, like Lindsay said, this is everything we do in the ICU on every patient. The question is, what's their volume status? And man, someone's going to make a lot of money when they can fix this and come up with a good way to measure volume status accurately and something that's reproducible that we can use. The sad part is we'll probably be out of a job then. Because if it's as simple as, I remember ignorantly saying when I was new to all of medicine, an elevated lactate, all it means is, you hold up a bag of LR and a bag of NS and you say, which one am I going to give? That was the workup for an elevated lactate. And it's like, man, that was a dumb thing to say. And so I look at it now, it's like there's so much more that goes into it, which thank God, that's why we have jobs. And that's going to keep us employed for a long time. But it's also the fun part is trying to work down that differential about what's actually going on. Anyone else have any comments?
I guess I would ask a question, when talking about the ability to get lactate or base excess intraoperatively, what would be an appropriate time frame for that? And between those intervals, and what surgeries would really benefit from that in terms of like anticipated surgical time? Because we're not going to get serial lactates on every patient we work on. That doesn't make sense. But I'm just kind of curious what time frame or what patients you think would really benefit from this, and then the intervals with which we should be checking.
Anyone have any opinions on that?
I think the trend is the most important thing. So if you have somebody, if their lactate's going up into surgery, I mean, that's someone you want to keep a really close eye on. If they start off elevated, I also just want to make sure they'd be going down. And then I'm going to defer to my anesthesia colleagues, but I'm sure you guys do some testing like we do in the ICU. Again, if you're elevated or you're going the wrong way, to see if a fluid challenge is going to help, or if different vasopressors are going to help. Anyway, I'll leave that to Justin though.
Yeah, I mean, I guess my big thing with all of it is I want to see us do something before we check again. I see a lot of times where we close our eyes, put our hands over our ears and hope that something changes, but we actually haven't done anything to potentially fix any of the problems. So it's like if you wait 4 hours, but to your example, to your case where no fluid's been given, nothing's really changed. Well, why would you expect the lactate to be any different? Even if the problem is volume status, you haven't addressed it. So it's one of those where, in terms of the interval, it could be 2 to 3 hours. I could see if someone's getting a massive resuscitation, they exsanguinate and their lactate's elevated. Checking one in an hour or two is not unreasonable. It's just really looking at, well, what did I do, and do I really think I addressed the problem or started to address the problem, or did I just, was it wishful thinking that something would be different at this point? I think in reality, with the length of time that you're in the operating room, you're going to have time to check one, I would say. And I would start there. And, with all labs, I personally don't like intervals and sticking to intervals. I like deciding lab by lab. It's like, okay, I'm this worried, so therefore I'm going to check it in this amount of time afterwards, after I do this maneuver or this intervention to hopefully make a difference. Because to me, that's the whole point of labs. It's not to trend them, it's to, make it some type of intervention and see if I'm right, get some feedback as to, is this the right way that I'm going or not? So I mean, that's my take. I know if there are other anesthesiologists that want to weigh in, I kind of treat it case by case and lab by lab before I decide how often to get it. No other anesthesiologist wants to talk up. So, maybe Dan's coming on.
It's me. It's Dan. Hi. Thanks, Kate, for the perspective. I appreciate being able to try at least maybe understand the perspective from your end, so we can work better together. For labs and things for me, I'm always looking for a change. I hesitate to use the word reactive, because, you know, if we get big blood loss, let's check a lab. Or if we do this, let's check this and see where we're at. I think a lot of times with the cases that we encounter in 4 and 5, it's where are we starting going into the procedure, and then what interventions do we need to make during the surgery to make sure that that patient gets out of the operating room safely and that you all can complete your work. So I personally try and use it as more like what Justin's been saying, of like, what am I going to do with the information? A lot of these situations, when you've made the call to bring them to the OR, it's our job to get them through the OR also. So I'm less worried about criteria going there and what I need to do to make sure that they are as optimized as I can in whatever situation they're at to get through it. And oftentimes the labs I'll use to just guide the resuscitation. You know, personally, to me, base excess is kind of a mystery. I don't, you know, people have tried to explain it to me, and in my brain, I just don't get it. The number goes up, down, whatever. I'm looking at the lactate and the hemoglobin and oxygen delivery for that, and then base excess, I guess, for kind of volume overall. It's my very simplistic regional mindset for trauma anesthesia.
No, I'm right there with you with the base access. It's taken a long time to come up with some warped idea about why it should be more reliable. And we probably could spend an entire hour just talking about this, and maybe we should. I see Mary Hannah on. I know she gave a talk a couple years ago when she was here as our fellow on acidosis and trauma. And you know, it's always something we can revisit and talk about some more. I think the one advantage base access has over everything else, or at least compared to lactate, is it's not a molecule that has to be cleared by something. To me, it's a chemical reaction. It's just a monitor of buffering, and that changes a lot quicker than a molecule that has to be cleared. And so maybe we'll get a better response or see a more accurate picture of what's going on in terms of what we're fixing. But I know there are probably chemists out there that could give a much better explanation. Well, I believe we're right up till 6. If anyone has any other comments or questions, please feel free to email and I can pass them on. Once again, thanks for coming, and I'll have the invite out for next month. We're having one of our colleagues from shock trauma will be talking. I'll make sure to get that invite out soon. So thank you guys very much.
Awesome. Thank you.